Welcome to The Explainer. So today, we're tackling an absolute cornerstone of obstetric emergency management. If you're prepping for your MRCOG exams, or honestly, if you just want a really solid refresher on your critical labor ward skills, you are exactly in the right place. We're going to enthusiastically distill the critical, evidence-based recommendations from the RCOG into a high-yield structured format. Because, look, cord prolapse is an acute, life-threatening event for the fetus. And knowing these precise guidelines, it isn't just about passing an exam, it's literally about saving lives when every single second counts.
Okay, let's dive right into this. We're pulling our content today straight from the official RCOG Green-top Guideline No. 50. This is the definitive standard of care, completely shaping how clinical negligence schemes and risk pools assess maternity risk management in the UK. We're going to break this incredibly comprehensive document down into crystal clear facts. We'll be focusing on the exact metrics, the actions, and the definitions that examiners absolutely love to test, and that clinicians just need to know cold.
Here is our roadmap for the explainer today. First, risks and antenatal care. Second, diagnosis and immediate action. Third, optimal mode of birth. Fourth, community and viability scenarios. And finally, clinical governance and training.
All right, Part 1, Risks and Antenatal Care.
So this section is really all about anticipation. Before the alarms start blaring on the labor ward, what are the clinical clues and definitions we need to have firmly established in our minds? First things first, MRCOG exams love testing the exact distinction between these two terms. Cord prolapse is defined strictly as the descent of the umbilical cord through the cervix alongside or past the presenting part in the presence of ruptured membranes. Now, on the other hand, cord presentation is the presence of the umbilical cord between the fetal presenting part and the cervix, but this can actually be with or without intact membranes. Keep that absolute requirement for membrane rupture firmly tied to your definition of prolapse.
Now, you've kind of got to mentally categorize these risk factors into general and procedure-related. General risks are things like multiparity, low birth weight, breech presentation, and polyhydramnios. But here is the critical, highly testable fact. Approximately half of all cord prolapse cases are actually preceded by an obstetric intervention. Yeah, half. These procedure-related risks include artificial rupture of membranes, especially if you've got a high presenting part, vaginal manipulation of the fetus, and external or internal versions. Because of this, the guideline strictly recommends keeping upward pressure on the presenting part to an absolute minimum during these interventions.
Which naturally brings us to a really common clinical question, and honestly, a classic trap for exam candidates. Can cord prolapse actually be accurately predicted antenatally using our standard imaging tools?
Consider this a massive red flag for your exam prep. The guideline is definitively clear here. Routine ultrasound examination is just not sufficiently sensitive or specific to identify cord presentation antenatally, and it should absolutely not be performed to predict cord prolapse outside of a research setting. The only real exception they mention is that selective ultrasound screening can be considered for women with a breech presentation at term who are specifically considering a vaginal birth. Otherwise, routine scanning for this is entirely off the table.
Let's move on to Section 2, Diagnosis and Immediate Action.
Okay, the membranes have ruptured, and suddenly you've got an abnormal fetal heart rate pattern. We are now shifting gears into the acute skills and drills phase. When prolapse is suspected, an immediate digital vaginal examination is mandatory. Once you confirm it, your next actions must be rapid, consecutive, and extremely precise. Here is your exact mechanical sequence before full dilatation. Step 1, call for immediate assistance and prep for theater. Step 2, elevate the presenting part. You can do this manually with 2 fingers or by filling the maternal bladder with 500 to 750 milliliters of saline. Step 3, positional changes. You want the mother to adopt the knee chest or the left lateral position with a head down tilt. And Step 4, consider tocolysis like subcutaneous tributylin. This helps reduce contractions while you prep for a C-section, which is especially important if delivery is going to be delayed.
So the crucial point here is understanding the clinical why behind these mechanical steps. We keep handling to the cord to an absolute bare minimum to prevent reactive vasospasm, which would just cut off blood flow. We elevate the presenting part to prevent mechanical cord compression against the pelvis. And listen carefully to this heavily emphasized negative recommendation. There are insufficient data to evaluate manual replacement of the prolapsed cord above the presenting part to allow labor to continue. Do not do it. Seriously, this practice is strictly not recommended outside of a clinical trial.
Right, let's transition to Section 3, Optimal Mode of Birth.
Once you've initiated all those immediate temporizing measures, you have to transition instantly to the delivery decision-making phase. This is exactly where clinical judgment and strict, testable timelines intersect perfectly. 30. Lock this number into your memory. A Category 1 cesarean section should be performed with the aim of achieving birth within 30 minutes or less if the cord prolapse is associated with a suspicious or pathological fetal heart rate pattern. Now, the guideline wisely notes that this should be done without ever compromising maternal safety. And while the median time achieved in actual audits is often much faster, 30 minutes is the acknowledged standard target interval for a Category 1 section. Now, while a cesarean section is the recommended standard to prevent hypoxic acidosis, there are a few caveats. A vaginal birth, usually operative, can be attempted at full dilatation if you anticipate it can be accomplished really quickly and safely. Another exception, a breech extraction is totally appropriate in specific circumstances, like after an internal podolic version for a second twin. And remember, if the fetal heart trace is actually totally normal, you can consider a Category 2 C-section, but that trace requires continuous, intense assessment. Finally, do not forget your documentation. You must always take paired cord blood samples for pH and base excess right after the birth.
Jumping into Section 4, Community and Viability Scenarios.
Moving beyond the fully equipped standard hospital labor ward, we've got to look at the edge cases. The guideline explicitly covers scenarios that happen out in the community, as well as those really agonizing situations involving extreme prematurity. If you're advising a community midwife or a patient over the phone, positioning matters immensely, and it actually changes based on the situation. If a woman with a known cord prolapse is at home waiting for the ambulance, advise her to assume the knee-chest face-down position. However, contrast this with what happens once she's actually in the ambulance. The knee-chest position is incredibly unsafe in a moving vehicle. During ambulance transfer, she must be switched to the exaggerated Sims position, which is left lateral with a pillow tucked under her hip. This is a highly specific, very testable distinction, so keep it in mind.
When prolapse happens at the extreme threshold of viability, and they define this precisely as 23 weeks and 0 days to 24 weeks and 6 days, the rules completely change. Here, expectant management should be discussed with the parents. Women must be counseled on the highly difficult choices of both continuation and termination of the pregnancy. And again, even at this extreme premature stage, the guideline reminds clinicians that there is still absolutely no evidence to support attempting to replace the cord back into the uterus.
And finally, Section 5, Clinical Governance and Training.
Look, excellent clinical knowledge is completely useless if the system around it fails, right? Examiners and clinical directors alike heavily emphasize this governance section because it ensures long-term patient safety and systemic improvement. And this brilliantly illustrates how modern obstetrics focuses on the entire patient experience, not just the acute medical intervention. Following a cord prolapse, you must offer an opportunity to discuss the events with the woman at a mutually convenient time, because this really helps mitigate post-trauma psychological risks. Administratively, clinical incident forms must be submitted for every single case. The guideline also strongly recommends using pre-formatted sheets for documentation, which have actually been proven to improve the accuracy of clinical records during emergencies.
Furthermore, just reading the guideline isn't enough. Physical rehearsal is literally mandated. All staff involved in maternity care must receive multidisciplinary training that specifically includes team rehearsals, often called skill drills, for cord prolapse. Why? Because the evidence proves it works. Studies referenced right in the guidelines show that this exact type of practical training dramatically reduces median diagnosis to birth intervals. In one study, they dropped the time from 25 minutes down to just 14.5 minutes, and that directly leads to improved neonatal outcomes.
Which leaves us with this final vital thought. We've mapped out the risk factors, the rapid diagnosis, the urgent positioning, and the strict timelines for delivery. We know the protocol inside and out, but when an umbilical cord prolapses and the fetal heart rate drops, every single second counts. So ask yourself, is your multidisciplinary team rehearsed enough to beat the clock today? Thank you so much for joining me on this explainer. Keep reviewing those guidelines, and I'll see you in the next one.